We're super excited to be here today. Pleasantly would like to introduce Karen Tachian. Karen is a Senior Director over Network Regulatory Operations at Healthcare Service Corporation. Karen's team has responsibility for enterprise network adequacy, regulatory submissions, and mandates. Karen served several leadership roles at HCSC, including the Medicare division. She's also worked at a small health plan outside of HCSC and owned and operated her own business. Thank you, Karen.
Thanks for having me, Bob.
My name is Bob Tavernier. I'm a solutions executive here at Quest Analytics. I've worked with some of you in the room. Thank you for coming. My focus is predominantly client-facing, especially in the network performance space. Prior to Quest Analytics, I served in a number of leadership roles at HCSC as well, focusing on marketing, network, government programs, IT, claims, and customer service. So super happy to be here today. We're super excited to talk with you about the Becker's Healthcare Survey. There's a lot that's going on within the industry. Think about what executives are challenged with, not only in staying competitive within their market, but also how do they continue to become not only competitive, but really focusing on growing their market share in terms of membership growth overall, and really focusing in on network. How do they keep up with ultimately the regulatory changes across different lines of business? So we've had an opportunity to partner with Becker's Healthcare to ultimately interview executives from directors and above. What's interesting is the survey actually closed inside of 2 weeks. So imagine being able to get directors and vice presidents, as well as C-suite individuals to be able to respond, to get 100 responses inside of 2 weeks. That's amazing. Thank you, Beckers, for that. We've got a lot to talk about in terms of network design. What we'd like to do is share a little bit of the demographics around the survey itself. When we think about the respondents, this included C-suite representatives at 1%. It included vice presidents as well as directors. From the overall line of business perspective, there was a significant focus around commercial lines of business, as well as QHP Marketplace, followed by Medicare Advantage. How many regional plans do we have here in the house? Any national health plans? Okay, we've got a mixture of both. Wonderful. We're going to share the perspectives on both types of health plans here today. When we talk about the different leadership roles, we're really thinking about what are the different levels of responsibility from a functional perspective. As you can see, provider network performance represented 26% of the executives that took the survey. Provider network compliance, 32%, as well as Karen, along with 42% that were primarily focused on building out their networks. One of the main questions that we asked executives were, what are the top 3 priorities that they're focused on in 2025? Interestingly enough, lowering admin costs, I'm sure many of you have those in your annual goals, but lowering admin costs was number 1. And again, this is a network performance survey, so it's very interesting that was number 1. Improving clinical quality, again, number 2. Very interesting that this level of information is here. And number 3 was ultimately improving member satisfaction. As you know, it's not just about building the right networks. It's not just about maintaining your networks. Ultimately, it's about your members and really thinking about your member experience and ultimately member satisfaction. Karen, would you share with us what your organization's top 3 priorities are for 2025?
Yeah, sure. So at HCSC, our top priorities are not much different than what you see on here. Improving member access to care is definitely number 1. What does that mean? So whether it's expanding our networks, optimizing our networks, and all opportunities that are available to us, that's definitely a huge priority. Of course, that encompasses quality, as you can see on there. The second one is decreasing overall cost to care. So not just administrative costs, but member costs as well. That's really important. And then member satisfaction as well. We want to make sure our members, especially our very committed members who have been with us for a long time, are able to get the same type of care and access to care, especially as they transition through different phases of life.
Thank you, Karen. It's interesting, just listening to Karen and thinking about the survey respondents. 65% of respondents equated network design to ultimately their organizational priorities. It's very interesting. Again, thank you, Karen, for your responses. What's interesting is the executives were asked about the data quality gap. And I'll actually talk through this piece. When you think about the highlights in terms of competitive network differentiation, provider cost and quality, member access to care, those were ultimately the top three areas that were most important to executives. Yet when you think about the data quality, members' access to care, the quality of data was only considered moderate. When you think about the provider cost and utilization, the executives agreed that ultimately this was really considered poor quality. And then lastly, from a competitive network perspective, this was ultimately the highest at 71%. So payers may have homegrown information, they may be purchasing data. At the end of the day, they're not satisfied with the level of quality of data that they have that they can utilize to make informed decisions ultimately around network performance. Karen, can you talk a little bit about just the data quality gap within HCSC and how you value data in terms of your team's role day to day?
So some of my peers and colleagues are in the room, so I have to be careful with how I answer this. No, I think especially for some of the HCSC folks in the room, what we find is that we spend a lot of time internally mining, sifting, and understanding our data. It takes a lot to get gainful insights that you can take strategic steps or find solutions around. So we spend a lot of time there. I'm pretty sure, and again, please raise your hand if you feel differently, most of you will agree that a lot of the time the information you get outside of your own four walls, that's often a barrier. So any publicly available information, whether it's about a provider or a member, sometimes it does not get you what you need in order to meet some of these strategic priorities.
Great. Thank you, Karen. Mm-hmm. When you think about regulatory actually impacts everyone within the health system, whether you're a payer, you're a provider, you're a hospital system, you're an ACO, et cetera. As you've seen, regulators are continuing to shift in terms of their focus areas. They're applying a higher level of scrutiny. At the end of the day, it's not because they're trying to be traffic cops, right? Their focus is ultimately thinking about the member experience. When you think about the level of data and the integrity of data, this is where it's really getting into outcome-driven measures. So if you're thinking about, yes, I've got to have a network, yes, it has to be adequate. What are some of the other things that are critically important when a member's shopping for coverage? Is there a provider in the network? Or perhaps it says it's in the network, but maybe they're a ghost provider and they say that they're supporting a certain line of business, but they're truly not. These are the things that regulators are watching out for. If you think about the member experience of, I'm calling a doc, I'd like to be able to get an appointment. What's the appointment wait time? How far am I from that doctor? Do they offer telehealth services? Are they culturally competent? Just really thinking about that paradigm shift of not only you as a organization and building your network, but then putting your member's hat on and thinking about truly that experience. So when you think about that regulatory shift, gone are the days of 6-month and 12-month audits. The regulators at the state level, at the federal level, they're spending those regulatory audits up on a quarterly basis. We've got some information that we'll talk a little later on around some of the state policies, including State of Illinois DOI. So love to share that with you. As we think about the granularity of data, this is where we start to get into claims intelligence. The regulators are actually paying more attention to claims than ever before. If you're thinking about claims level of data, the cost, the quality level of providers, at the end of the day, now we're thinking about clinical outcomes. How do you ensure the member's getting the right level of care at the right time in the right place? Again, thinking through the claims intelligence, ultimately having the ability to improve the efficiency of that ecosystem for members. With the additional level of rigor that the regulators are adding, this is where it begins with a higher level of accountability, not only on providers, but also for the payers in the room, hospital systems as well. It's that continuum to focus on how do we ensure that there's a continuous level of accountability, and at the end of the day, reducing the risk of negative member experiences. So ultimately, there's requirements around provider directory accuracy and being able to keep up that. The industry knows that roughly 50 to 60% of a provider directory has churn throughout the year. So that information is constantly changing. How are you keeping up with it? The regulators know this, right? And the regulators are going to call you on it. So having sound systems in places are critically important. The last thing, and again, where we started with, is the regulators are ultimately focused around the member experience. How do you help to ensure that the member has a satisfactory level care journey, depending on whether they're early in their stages of life or later in their stages of life? It's that same level of committed detail when you're thinking about the true journey. Are there appointment wait times? What's the, again, travel distance? What is the pattern of care? And do you have the right network set up to ultimately support your members across the different lines of business that you're ultimately supporting? I'd actually like to ask Karen if you could share a little bit more information about how you're viewing regulatory and how do you compare and compete with resources inside your organization when you have a regulatory response and there's also competing priorities around optimization, network growth, profitability.
Yep. And different regulators wanting different things.
Exactly.
So I think the goal is to always find alignment between your strategic priorities and then also making sure you're compliant, because you can't go very far if your networks are not meeting the bare minimum, right? So it's about understanding where are there levers of opportunity with your regulators. So where are there commonalities where you can gain efficiencies, because that's really important, especially when you are always resource constrained. And then how do you fold that into your strategic priorities? So if your goal is to expand your networks, how do you do so in a way where you're able to get every provider your regulator is asking you to, or you're able to conduct wait time surveys independently and make sure that they're meeting what your regulator wants, especially now that you have to file them a lot of times. So it's about building a lot of the basic regulatory requirements that continue to grow and evolve into the overall roadmap of your network design.
Thank you, Karen. Mm-hmm. On a related topic, just, as again, thinking about the regulators and thinking about the constant shift of regulatory policy. It's not only happening at the federal level, it's also happening at the state level. So a few examples that you can see on screen is Illinois Department of Insurance, Oklahoma Department of Insurance, the New Mexico State Authority, and really thinking about the currency and level of clinical activity of the providers. You can see in Illinois and Oklahoma that if there's no claims activity in 12 months, they want the providers and payers to work together to be able to update those directories, right? They really want this information very current. If you look at New Mexico, it's a 6-month turnaround. And if you're no longer going to be supporting a specific line of business, it's absolutely critical that the payers and providers are ultimately working together to support these policies. So it's a very interesting viewpoint. Karen, anything you'd like to add in relationship to the state policies?
I touched 3 out of 4 of these, so it hits home for sure. The only thing I would add is this goes back to my earlier point about commonalities. You'll see, again, first it was directory accuracy, which again continues to grow and evolve. Now it's a little bit more around dormancy or zero claims activity, which you can see some of those constructs on here. And then of course, wait times, right? So I think we're all seeing some of the growing requirements. And again, it impacts both the payers and the providers as well. And most importantly, the goal is to make sure your member is not caught in the middle.
Great. So I'd like to talk about network design. When we ask the executives about the importance of network design, you can see the middle bars here in terms of member satisfaction, improving clinical quality, and ultimately expanding into new markets. These are considered the most essential areas within an organization around thinking about network design. How many of you remember what the organizational priorities were in the beginning? Lowering admin costs, improving clinical quality, improving member satisfaction. You can see 2 out of the 3 of these are a direct correlation around really thinking about network design and taking that to the highest of levels in terms of organizational priority. If you look at the next tier, in this view, we've got lowering admin costs. You also have expanding into new markets, improving Medicare Advantage star ratings, as well as driving membership growth across existing markets. So there's some common themes here in terms of not only growth, but also increasing satisfaction, being able to expand your markets, expand your growth by really focusing in and doubling down around network design. Karen, when you think about network design, what would you've said in the past that you like to view it as a combination of an art and science between network design and optimization. Would you help explain that?
Sure. I'll give you another bad analogy. You know, when you have a recipe that you're supposed to follow, but then you kind of put your twist on it, I think that's a lot of where payers are having to be a little bit more creative. The reason why I say, or I call it a little bit of an art and a science, is because you have your regulatory expectations. And so those are your cut and dry, black and white, what you're supposed to meet, right? But it also depends on where you are. It depends on your provider landscape. If you're in a rural area, your provider landscape looks really different than if you are in like Metroland Chicago, right? You then have to look at your members. Who is your population pool when you look at your members? Who has the most clinical risk? Who has the least access to care? Where can you glean from your own internal insights, like through claims data or even some of your utilization patterns? And how can you use that to leverage where you need to go next with your network, whether it's a new network, an expanded network, or a sculpted or optimized network? So that's what I mean. It takes a little bit of iterating, but it also takes getting to know the region you're playing in as well as your members. And that's where you can try to be as predictive as possible, but truly it's about really understanding and enriching what you have available to you from a data standpoint.
And how many states does HCSC have again?
Quite a few.
Thank you.
Uh-huh.
So we'd like to take a deeper look into the market and competitive intelligence. And I don't know if can everyone see this screen? Okay. What's interesting is we're looking at the actual usage of network data versus the average importance of network data. Access to care, as you know, is critical. It's the highest used metric on this screen, right? But when you look at the importance of data, now you're starting to look at some very interesting trends. Provider referral patterns and network adequacy are considered a lot lower in this view, according to the executives, in terms of average importance. Provider quality is considered, about middle level, which is very surprising, right? Again, you want high quality providers. You really want to focus in on ultimately your clinical outcomes. And if you look to the far right, you can see the competitive network composition and provider cost and utilization as a lot higher level of importance, but still not the highest. So it's a very interesting dynamic when you're looking at these, the data overall, and what's the story that it ultimately is trying to tell. Are payers do they already have network adequacy nailed down? I guess it depends on the payer you're talking to, correct? But are the payers truly being able to leverage competitive network data? In most cases, as you saw earlier, there's a look back that says really the providers do not have access to high quality competitive network data, but yet it's considered extremely important to them. So it's a very interesting metric that's going on here. Karen, would you share your thoughts around the scatter plot?
Sure. So I'm not surprised to see profitability to be on the upper end in terms of like essential, most important. I'm also not terribly surprised to see that it's some of the usage is like somewhere in between, because sometimes it's difficult to understand what your organization and how it defines concepts like quality or VBC, which of course are in the middle. This makes a lot of sense to me. I think getting some of the basics, like a basic referral pattern or meeting network adequacy, I'm not surprised to see that as being not quite as important. I think it's an essential. Most payers, whether you're regional or national, have seemed to figure out a way to go around it, like a certain rigor. I think now as you get into more challenging concepts to define, because you can define quality a multitude of different ways, whether you want to look at it from a clinical perspective or a financial perspective. Same with BBC. I think now you're starting to see how different payers are needing to really sit down and define what that means to them. Because again, if you're national, you have efficiencies of scale at your disposal. There's different levers you can pull. If you're regional, you have to look at things a little bit differently. But regionally, you have very, very rich data, and you tend to be very community driven. So you tend to know your population better. So like I said, it's interesting to see this, but I'm not totally surprised.
Thank you, Karen.
Mm-hmm.
So one of the interesting areas is we've covered a lot of different information today, but where do you start? You heard about adequacy, you heard about Access 2.0, really going beyond time and distance standards. You heard about how important network design is in terms of not only your competitive landscape, but your own profitability or growth, and the ability to ultimately improve member satisfaction. But as you're honing in on that data quality gap, it's what we're trying to understand is, where do you start? Do you start with regulatory? Do you start with competitors? Do you start with the provider quality of data? Do you look at high utilizers? Where is the best place to start in terms of network design, in terms of optimization, and ultimately, what can we give to you in terms of takeaways in this direction? Karen, would you share your perspective on that?
Sure. This is a very layered answer, right? So I think you have to look at the entire ecosystem. And I think as an organization, you have to prioritize. You can prioritize just annually. Here are my top 5 priorities, but you can also prioritize in terms of what's on your strategic roadmap for the next 3 to 5 years. Some of these data concerns and data quality issues, as many of you, I'm sure, feel this on a day-to-day basis, you can't solve them in a quarter or even in a year, right? And so I think it's really important to get aligned on what's feasible and where your low-hanging fruit opportunities are. Again, I'm a firm believer as far as like what I've seen so far in terms of your own organization will have a lot of information. It's just a matter of, are you able to mine it, sift it, and understand it enough to give you the insights you need to either meet those priorities or to give you a better sense of where you need to hone in to go. Again, I think the regulatory landscape, not to sound like a broken record, is going to continue to become a lot more challenging no matter which line of business, no matter which geography you serve. So I think it is essential to make sure that that's folded into your overall network design. But I don't think that has to be the end of it. I think it can really help serve as leverage for like building competitive but also sustainable networks.
So Karen, to the point you just made in terms of it doesn't have to be the end of it, do you think Access and Adequacy 2.0 is a fad, a phase, or do you think it's here to stay?
I think it's going to be here to stay. I think it's going to take different shapes and shifts over time because, again, you're going to see different trends, whether you're talking about a state regulator or a federal regulator. But I think that at the end of the day, the goal, and this should be all of our goal, right, of course, here, is to make sure that we are making sure our members have as much access to care as needed, especially when it's the right type of care, as you mentioned earlier, but also making sure that we're attributing to lowering the cost of overall care instead of continuing to see it rise.
Thank you, Karen.
Thanks, Bob.
Bob and Karen, thank you very much. Thank you all for your questions.
Thanks, everyone.
Thanks, everyone.
Have a good one.